everybody, and it is the 10th of April. As always, on the 10th, it is the Chairperson Imaging Committee, Dr. Neena Malhotra, who comes to you for a podcast with a celebrated guest. So before we start the podcast, I take the pleasure to welcome the President Fogsi, Dr. Sunita Tandulwadkar, who is the brainchild behind this podcast, Gyan Pravah. An earnest effort to share knowledge, not just to our colleagues, our friends, but also to many viewers, which includes our patients. It's indeed a pleasure to welcome Dr. Sunita Tandulwadkar on this podcast, which marks the third for me on this tenure with Dr. Sunita Tandulwadkar. Welcome, Dr. Sunita.
Thank you. Thank you, Neena. And it's so wonderful. In one frame, I have two great friends of mine. And coincidentally, both from Delhi, though one keep on dogging between Delhi and East India. But Deepika, thank you so much for coming on a Fogsi platform. And Neena, thank you so much for selecting the speaker of this level. It's always great pleasure when two academicians are going to have their dialogue. I'm sure the viewers will have a great time together. And Deepika, our methodology is only two of you will be in the frame and I will be watching or hearing both of you from the different link. So thank you so much for coming. And it's after ages, I think we both are meeting each other personally. So maybe after my presidency, first time I'm meeting you, Deepika. But I keep on watching you, your podcast, on your WhatsApp. You are very active. You are a real academician. Though Neena should give your official, real introduction. Back to you, Neena.
Thank you so much, Dr. Sunita, for those words of wisdom and encouragement. We will go ahead with the podcast. Thank you very much. So, dear viewers, the topic is Healthy Beginnings, Hopeful Future, which is the slogan for WHO 2025. In fact, almost took 20 years for WHO to make mother and child, maternal and child health at the corner or emphasis of this slogan. Way back in 2005, when the slogan was, make every mother and child count. So it's indeed a pleasure to speak on the subject because we know that in India, as per the NFHS data 5, between 2019 and 2021, the maternal mortality in India has declined to 97 per 100,000 live births, a decline from the previous numbers of 130 per 100,000. And if we look at it, this has been a commendable decline of nearly 60% decline in comparison to most of the other low middle income countries, where India has made a tremendous performance. Thanks to initiatives by government bodies, improved healthcare access, better medical interventions, and of course, a very, very big effort coming from our national body, Fogsi, which is aligned with many, many international players, including the WHO and the JPIGO and many other initiatives by Fogsi. We take pride in saying that we are a country which is doing really good in terms of these indices. So to deliberate today on this Healthy Beginnings, Hopeful Future, I have none other than a very celebrated guest, Professor Deepika Dekar, who I take the pleasure to introduce. Professor Dekar joined the prestigious All India Institute of Medical Sciences in 1984, and ever since she joined, there was no looking back. She became a faculty, rose to the ranks of the professor and head of the unit, and was the proud individual who initiated the very, very dynamic Maternal Fetal Fellowship Program. To her credit are many firsts. She took the initiative of establishing and taking the fetal medicine to great heights at the All India Institute, pioneering numerous intrauterine procedures, including cord blood transfusions, in utero procedures, including radiofrequency ablations for twin transfusions, and many more. Well, she didn't stop there. She moved ahead in her career to become the director of Kalyani, All Institute of Medical Sciences at Kalyani, and then moved further to become the Vice Chancellor of the Assam Medical Universities. She has been a role model to many, mentored many, including me, and I think her persona is something which charisma and the persona really, really impresses. So welcome, Dr. Dekar, to this podcast of Gyan Pravah. So as we move forward, I think I just gave the statistics, but I would really tell Madam and also people that we will not talk of just the data. We'll go further from this healthy beginnings to hopeful future. So, ma'am, how do you see, the progress that India has made when we look on the global front, when we look at maternal and child health? How do you sort of foresee? Because you've been here watching this for decades, and with your career that you have seen, how do you see this move?
India has made, first of all, I would like to thank you, Dr. Neena Malhotra, and of course, our president, very good friend of mine, Fogsi. So, and I'm very happy to be part of this podcast, which is really an interesting way of disseminating information. So, like coming to the point, I think over this years, especially in the last 4-5 years, we have made tremendous progress. The new government has really made stunning progress in maternal and child health. The things have really been game-changing. The maternal mortality, the fetal mortality, the neonatal mortality have all come down at a much higher rate than worldwide. If you look at the statistics of the United Nations, of WHO, we find that we are making much faster progress than any of the other countries, especially the developing countries. So versus the global progress, we are doing very, very well. And I'm really proud that all our indicators, are showing so much better in comparison with the global reduction in the rates.
Yeah, certainly. If you look at institutional deliveries, we've almost touched, pan-India 60%. And, there's some states, down south, Kerala, Andhra, Tamil Nadu, where, the SDG goals of 2030 have already been achieved. In fact, they have almost 97% institutional delivery, which again came as a very big surprise to me while I was kind of doing that, considering that the World Health Organization Day, WHO, was 7th of April. So, ma'am, I think
our own country, we have so many, new maternal health programs. Institutional deliveries was the one which started in the beginning. And now almost 80-90% of deliveries are happening in the hospitals, the government hospitals. So that is contributing to it. Then we have the Janani Suraksha Yojana. That also has really been very, very useful. And so it has attracted people to come to deliver in the hospitals. So we are seeing less of PPH, which is the number one killer. Then, of course, we have the Shushu Suraksha Karyakram, JSS scheme in AIMS. We were really making so much use of this. And it was really, really very helpful. So, and then, so many other incentives, Pradhan Mantri, and then the Suman. So all these things by the government has really made a very important impact on the figures in the country.
Yeah, definitely. So, ma'am, I think we still have, we're looking at, SDG goals where we look that we should be we'll be further declining, and we should target, less than 70 maternal deaths per 100,000. Do you still see there'll be some challenges? Because, India is not one, it's a diverse country. We've got like diverse states, diverse people. So do you say envisage there will be some challenges, or do you think we can make it at the same pace across the entire country?
Oh, the challenges are tremendous. There's so much challenges. And we all know that poverty is the number one problem. Then poverty is the number one problem. So though we have the facilities, the people who are still below the poverty line are not able to access the complete range of facilities that are available, despite what the government has, given almost free. So people, and then the awareness is not there. The awareness is not there. So people, even though the facilities are available, they are not being utilized. They're not being utilized to the extent that the government wants them to be. So I think the factors are education, which is leading to the poverty, lack of awareness, which is leading to, again, non-utilization of the facilities given by the government. So these things are there. Of course, in the cities, we have very good roads, but if you go to the villages, the roads are still not as good as they should be. I know of instances where people take 2-3 days to reach a maternity center, and they could very easily die on the way. So, the agenda for sustainable development, that the people, planet, prosperity, peace, and partnerships. So everything comes into it. We still have a long way to go, but we have our sights focused and we'll surely get there.
Yeah, so we've got a hopeful future, certainly.
Yes, at
So-
least by 2030, what is our goal? We should be able to do that.
So I just want to share, since you've been an expert in maternal fetal medicine with so much passion, while we are seeing a decline in maternal mortality on the stillbirth, side, we've not made a very big, dent, as you would put it, we still have a stillbirth of 9.7 as against, 12. So where do you see the stillbirth rate? Do you think it still needs a lot of, focus, or do you think we have made an impact there in terms of the stillbirth rates?
Yes, we have made an impact, but still, again, as you said, that we are still far behind because there are certain conditions which, despite being there, like pregnancy-induced preeclampsias, growth restrictions, all these are there, and not everybody is availing ultrasounds and the diagnostic procedures. So we still do get a lot of cases which are missed. So the near misses are the ones which are contributing to the to the neonatal mortality and the stillbirths. So if we could, and our ultrasound technique for India, it is so difficult to get an ultrasound done by everybody because of the PCPNDT Act. So therefore, we are sort of very constricted in that area because ultrasound definitely is a very important way by which we can pick up complicated pregnancies. And so these are some things that we are. Also investigations. Now abroad, see, people are doing the whole exome sequencing as a routine. They're doing it as a routine before pregnancy. The screening procedures are so much in place that what we just have to do is the counseling and the prenatal diagnosis, which is not done here as much as I would want it to be done because of, number one, lack of awareness. Number two, again, they are still not provided by the government. They are quite expensive tests. And even if a person, there is an indication, they are not able to do it. And we know now that genetics has become a very important part of stillbirths. A lot of these unexplained stillbirths are genetic causes.
Thank you so much for bringing these. Yeah.
Undiagnosed.
I just stopped you. You can carry on. I sorry for interrupting. You wanted to speak something more on genetics, I believe. You wanted to speak something more.
I'm saying that there are many factors which are still contributing to the high rate of stillbirths. One of the biggest problem is the non-diagnosis of growth restriction. FGR is still very, very underdiagnosed, and therefore the patients are not being monitored, and the unexplained, what we call unexplained stillbirths, are actually something which you discover later that the babies actually had, growth restriction. Then the other causes are congenital malformations, and then comes the genetic disorders. And today only I was reading about arrhythmias, cardiac arrhythmias, and apparently what we see is just the tip of the iceberg. We are not able to do a fetal echo in every pregnancy, and apparently more than 20-30% of fetuses can have a cardiac problem, rhythmic problem, and they'll end up with stillbirths before we can diagnose them. So most of the unexplained stillbirths are really not unexplained. They are just undiagnosed.
Thank you so much for bringing the fact that there is a need of not just scan machines, but train people to do. And being a chairperson of the imaging sciences, what better person can I have than you to bring this, to reiterate that preventive obstetric definitely needs not just good scanning, but good individuals who are very well trained. And that's what is the effort of Fogsi. And as a chairperson, I wish to take this further.
Yeah, that is why I stressed on it, so that you
Thank
as
you.
a chairperson with a big body like Fogsi behind you, because when I was chairperson of the Genetic and Fetal Committee, then I tried to do a lot of things and did it also. And now it's your turn.
Thank you so much. So I know, having, been mentored by you, I just learned one sentence. Planning is the key to success. Plan well. Be it a fetal medicine procedure, be planning an event or conference. I think I learned so much. But then when we talk planning is the key to success, how do you see pre-pregnancy planning and counseling? Do you think it has got will it make an impact in improving maternal health? And if we really say, how do you take this pre-pregnancy planning for couples today?
Pre-pregnancy, I feel, and it has also been mentioned in many of the literature, that it is perhaps the most important visit a pregnant woman, a woman who is planning pregnancy and who will later on become pregnant can make. Because half the conditions, maternal conditions which are there, which cause problems in pregnancy, we all know that anemia is one of the biggest killers. It is not a direct, but can later on, we know about anemia in pregnancy, the other causes of anemia. So this, then hypertension, cardiac problems, thyroid, hypothyroidism is such a big problem in our country. And all these medical disorders, more than 10% of women are on medications. And they would be on medications for conditions where they cannot stop, like heart disease, epilepsy, so many other conditions. So if we know about all these before they start pregnancy, another big factor which we have in our country, and it is growing, is either undernutrition or overnutrition, either very low weight or obesity. And obesity is now becoming one of the biggest killers. Not only there are unexplained stillbirths, which we were talking about, also maternal complications like preeclampsia and all. So it's very important pre-pregnancy. There should be more awareness. Of course, WHO and the government are talking about folic acid supplementation. They are talking about pre-pregnancy checkups, rubella vaccination. But these are things which are very, very important. And we should have more awareness on pre-pregnancy checkups.
Good. So nice that you really touched almost most of the aspects, just not the medical, but how a woman should see their health. Now, when we talk, we talk as sort of academicians talking in tertiary setups. Things could be doable. We could still sort of guide patients because they reach. But considering that just 10% of patients across even big cities could reach to centers like AIMS or big tertiary hospitals, how do you think could be a way to sort of implement such pre-pregnancy counseling? What do you think would be the basic thing that you should advise to couples, maybe at a very basic or a primary or secondary healthcare levels? What will be the basics we can do?
See, Dr. Nina, in India, we have a very important, very good setup, actually. The ASHA workers, the primary health centers, this is where patients go first of all, the ones that 80% we are talking about. So it is the people who are working there. There should be more awareness, more training of these ASHA workers. Because now in practice, I know a lot of ASHA workers who bring in their patients. And when I ask them about what is the blood group, they have no idea. What is their hemoglobin? They have no idea. So unless we train the army of ASHA workers, the primary health centers, with all this, awareness programs, we can do extremely well, because that is the grassroots level that needs work, that needs to be done.
Yeah, and I think on this note, I think when you talked about knowing hemoglobins, I think it's a very big initiative of our President, Dr. Sunita Tandulwadkar, who talks on know your numbers. And I think the numbers include not just your weight, height, your hemoglobin, your blood pressure, and many things. And here I would like to reiterate, as you said, blood group. So I think today also we are seeing so many RH immunizations happen. And I think you being the lead, you said numbers, you set bars for the institute, which sort of give us so much impetus to move forward. So in today's day and age also, our trainees get to see, if you look at trainees from the UK or Europe, they hardly get to see an RH stimulation. Considering that you've been in this field of, fetal medicine for the last 3 or 4 decades consistently, how do you see the impact that has made despite the awareness that you created blood group? Do you think that still we are missing something, or where are we in our lacunae in our understanding that we still get to see so much of RH immunization reach for blood transfusions in utero?
Prevention is the key. Prevention is the key. Not many people will be able to do an intrauterine transfusion and manage these cases, but if they could at least prevent. I know that even now, RH grouping is not done universally. There are patients who do not get the anti-D prophylaxis after a miscarriage, after medical abortions. You know, there are so many finer points that people need to know. So again, the deliveries at home, the deliveries in the primary health centers, not everybody is getting prophylactic anti-D. So prophylaxis is the key to the prevention. And of course, every hospital, there should be centers where people are trained in doing intrauterine transfusions so that patients don't have to come all the way from very far places to come and stay for 3, 4, 5 months near around AIMS. Because I remember there was one patient who had come from Patna and she used to come very regularly for all the follow-ups and everything. One day I asked her, where are you staying? She's saying, I'm staying in the footpath. I mean, this is the status. She's staying in the footpath in front of AIMS and coming for IUTs. Can you imagine? So I'm saying that all the medical colleges should develop this specialty.
I think the agony
Now
of
we
the
have
woman.
endoscopy everywhere. Everybody is trained. So they should be trained in this specialty as well.
Absolutely. I think more than yes, why should a woman reach intrauterine transfusion? Why should the fetus need when we have
Yes.
a simple thing as giving anti-D, which could really, really circumvent the problem of ICU immunization? And I also feel that there are places where we know that we've given them anti-D, but have we given them an adequate dose? Perhaps underdosage could be another reason for them reaching to have intrauterine transfusions and fetal anemia. So that is
Yes.
something.
Yeah, absolutely. Because when I was the chairman of Fogsi, I used to go around saying, refer patients before hydrops develops. Because most of the people used to keep on monitoring them by ultrasound. And when hydrops developed, that means the hemoglobin of the baby is between 2 to 5 gram %. That was the time they were referred. So now at least the referrals, you know, we just had a paper and we find that the referrals before hydrops has increased. But what about the prophylaxis? So now we have to target more effectively prophylaxis, which you and Foxy can do in a better way.
Yeah, certainly. Now, I think there's something which I thought it's not talking about mortality, morbidity. I thought talk about, again, a key area where you really have taken the lead is pregnancy losses. And I think recurrent pregnancy losses, I think we would look up to how you manage them. And you had such a sort of flair. Today also, you know, when you see couples and families come with this problem, because this is something which is something which really, you know, depresses, stresses the couples. So where do you think today, when you have a couple with a recurrent pregnancy, you know, how would you think to be best guiding them? Because that's another way I thought you could throw light on the subject, because this is again a cause of concern to most of the, you know, young mothers or who have repeated pregnancy losses.
Yes, this is a very, very stressful situation, and obstetricians are the first line who should be able to actually have a basic knowledge of all the causes and manage the investigations stepwise. The commonest investigations and the commonest causes should be investigated first. Then we go on. You know, there is no point doing a protein C and protein S in the first visit. So it should be all, the protocol should be very well known to all obstetricians. Like I remember when we were doing infertility cases, patients were referred to us first with a diagnostic laparoscopy, even before doing a semen analysis. So similarly, in cases of RPL, you should have the common causes investigated first. So the common causes always come to an anatomical, the APLA, the immunological conditions. So these are the things that we need to see. After which, then we also, now the ESHRE has said that in recurrent pregnancy losses, the first thing that you should do is the chromosomal microarray of the abortus. You know, the investigations are going the other way. So the first thing we should do after we've, of course, done the basic workup is the chromosomal microarray of the abortus. And that is quite easy because you don't need to do a karyotype, but you should make sure that you have sent villi and you have not sent decidua. So on a petri dish, the obstetrician should really dissect out the abortus material so that they pick up the villi, because I get a lot of referrals where it is decidual tissue, maternal cell contamination. So the CMA is one thing which needs to be done. And after that, it's if it comes positive, then you need to go ahead with doing the couple karyotype. And if that is not showing and nothing else is showing, then we go on to referrals, higher referrals. So whole exome sequencing is something which is coming up, and it has been seen that even as high as 20 to 30% yield we do get. So these are all, of course, a very higher level counseling, which the obstetrician should refer the cases to the geneticists and the fetal medicine specialists after they have done a basic workup and not able to, so that they can interpret the test better.
I think indeed you've thrown so much of light on the genetic aspect, because, every time you see a couple, I think they are shuttling between a genetist and an obstetrician. And I think something which is very basic, as you rightly said, is look at the villi, just put them on a petri dish with a little bit of saline, and I think that's enough. But I think this knowledge has to be given to every obstetrician who's in training or who's in practice, that these things, rather than just so, and again, the very thought that you said, you have to reverse your thought. If there is an abnormality in the CMA, then you come back, look inwards into the karyotype rather than going the other way around as we were doing it in the years. And of course, as you rightly said, that a bit or understanding at the gestation, because when you have, couples who come with pregnancy losses after a loss of a cardiac activity, we start thinking of the APLA. And I think simple tests really do matter in our understanding rather than shooting up. Because at the end of the day, I still remember you telling us doing TORCH, which was so much in practice. And today, till date, we see a lot of GPs sending us referrals with saying the TORCH has been done. So I think that's something which still we feel is absolutely irrelevant in today's day and age.
TORCH infections are a problem, because we have seen that a lot of women are immune. That means they have got infection sometime in their lives. But the thing is that TORCH infections don't usually cause recurrent pregnancy loss. They can cause one loss. Do get a lot of patients when they come after one abortion. After one miscarriage, they come and want to know what it is. That is the time that you can do that. You can, because you won't go and do a CMA for the first miscarriage. But then if it's repeated, then it cannot be a cause unless the woman is, having she's on steroids or has some condition like that.
Yeah. So I know in a sporadic, one of these infections can be a cause, but when it's a recurrent pregnancy loss, I think one has to really think, do we really need to subject this couple and add more stress to the investigations?
Yeah.
No, I think we've always looked at the maternal side of things when it comes to maternal health. Do you think paternal health contributes to optimal pregnancy outcome? Do the fathers in this side or the male side of the embryo or the genetic contribution, does it sort of have a bearing on the outcome of the pregnancy, or how do you see paternal health as contributor?
Yes, the paternal health is now coming up, because one is the age. So we only think about the mother's age above 35 as significant, but now there are lots of studies which also talk about the fetal of the paternal age. So paternal age above the age of 40, these are coming up. And then a lot of stress these days. So there are lots of studies, and I also was doing a lot of them with the genetics department, that the semen, fragmentation index being high in cases of stress can lead to recurrent pregnancy losses, can lead to congenital malformations. So that is also important. And of course, the genetic factor. After all, half the genetics is from the father. So if the father has a balanced chromosomal abnormality, or there is a gene which is abnormal, that can cause. Now, with the Human Genome Project and with the whole exome sequencing, the whole genome sequencing, we are able to find that more than 50% of people have genetic abnormalities. Something or the other is there. And these can lead to recessive conditions, dominant conditions, and half of them is in the father.
Yeah, so certainly I think it's not the woman who needs to be investigated. Sometimes, and I remember of your publication that you had brilliant ones where you even looked at the sperm telomere and DNA fragmentation in women with recurrent miscarriages, which was
Yes.
a large cohort that you published almost, I think, 10, 12 years back. And that's what really threw us to thinking. And today, I think when we look at stress and overconsumption of, smoking, stress, all these things are certainly adding
Alcohol.
up to
Yeah.
alcohol. They're certainly adding. So do you think that there's another side to see that there's a delayed trend to delayed childbearing? When you was talking of paternal and, aging or advanced paternal age, even maternal age. So in the present day, when people are looking at their careers and chasing their career goals, do you think people like you and me, when they talk, we may look like obsolete, but then how do we sort of counsel the young, generation of who are really chasing their careers and they're chasing billions in their things. So
Yes.
do you think we sort of still need to have some value in talking, or you feel no, they can
No,
be.
certainly. See, times are changing, and however, the biology isn't changing much. And so, after the age of 35, it seems to be very young for people to get married nowadays. And to have a baby at 35, even if they are married, it seems too early, because I've gone through that process myself with my people that I know. Now, the thing is, however, that we should, this is our fault, I think, that we should talk more about egg freezing. We should talk more about egg freezing, because we should not cut down the career of an aspiring person. Women are getting educated, they would like to have a good job, they are ambitious. But at the same time, we have to think about how we can help them out with their personal career, having children. And I think this is one very good option which a lot of people are doing. They are freezing their eggs, freezing their embryos if they're married, and that has gone a long way.
Yeah, I think we
in
can talk, and if we
improving.
start, yeah, I think we start talking, we'll take another hour on this issue, because this is something which is really
Yeah,
kind of
but I think
area of
it's very
excitement
important
and
for those who are watching that they should know the options.
yes.
And you,
But
as IVF specialist, you should really set some guidelines about who is supposed
yes.
to freeze their eggs.
Yes, I think it's a very contentious subject when it comes, because I know there are a lot of, people who think that they're ensured their fertility, but certainly egg freezing may help them, but does not guarantee them a baby.
Of course,
It'll
but there
be
is
just
no
a
other
way.
option.
Yes,
Either they
considering.
marry and have kids early, or they freeze their eggs. There are no other options. No,
Yeah,
not
and
everybody likes to have an ovum donation.
absolutely, absolutely. So I think we've talked. I know that we are talking about moving from maternal health, looking at hopeful futures, and we really talked to things like women moving in society up the ladder, trying to understand, yes, they have not just career options, they have fertility options as well. Just to put it, I think I see Dr. Deka as a role model, and I think she has made a very, very successful climb in her career, moving as a clinician, academician, administrator, teacher, and then the vice chancellor of a medical university. And I would just go a little off track to ask, say, ma'am, how do you see, what is the mantra for your success, such a successful career? So, how would you describe your journey in success, and what would you attribute to your, I would say, recipe of success, where you put that? Because you've been a role model to many, including me, and I was simply not shy in saying that.
Okay, thank you very much. But I think the seeds of everything, of course, it comes from within. But I really appreciate the amount of work put in on me by my parents. Everybody needs a mentor. And I think no better than a mentor than your parents. So people, who are raising kids, they should make sure they have to be the role models of their children. So from a very young age, I was taught simple living, high thinking. And from a very young age, I used to, we had this mantra that early to bed and early to rise. And I remember I used to get up at 4 o'clock. Of course, our part of the country, the sun rises in the east, and of course it comes very bright by the time it's 4 o'clock, 5 o'clock. I used to regularly get up at 4 o'clock and finish all my work, and I never left any things for the next day. I used to finish whatever had to be done the same day. That was one thing. I was very, very disciplined. And I remember that in our school, we had on the timetable, we had to write, I will do my best and God will do the rest. So put in your best. That was what. The other thing that helped me was that I was the eldest. And I was always told that I have to make sure that my brothers, sisters grow up, confident and good. So I used to set an example. I used to set an example to them by doing all the good things. And that's what. But what I find is that discipline, perseverance, this is very, very important in life. And of course, be very simple, God-fearing, do the best for others, no negative thoughts. So these were the things that set me going. And of course, ambition. Ambition, I remember, I am not ashamed to say that I'm very, very ambitious. So when I knew that in my institution, there was no scope for me to become head of the department or director or anything, so I chose something else. So that's not the end of the world. There are so many alternatives. So I went, though people were not very talking good about other aims, I went, what is the harm? Let me see, I developed a new institution. So I joined Kolkata as the first director of Kalyani. But I always wanted to give something back to my state. So when the job of Vice Chancellor fell vacant, I thought I should go there. That's a higher post. And so that I can do something. So, this passion, even for fetal medicine, developing fetal medicine, I attribute my success in fetal medicine to Dr. Kamal Bakshi. She was the one who recognized I was really keen to do endoscopy, but she was the one who said, you have a knack for doing ultrasounds, you develop fetal medicine. And then in those days, nobody was doing fetal medicine except her. I'm talking about 1988. Even Dr. Suresh was not doing at the time, and he later learned from her, in fact, Dr. Bakshi. And then I took it upon myself to develop fetal medicine in AIIMS with Dr. Bakshi as my mentor. From one small OT in the corridor, which was just a 10-by-8 room. And luckily, when my husband became director and I found that we could get so much funds and all, knew the exact way of getting funds, we developed the first, fetal medicine center, literally in 3 rooms over there. Went abroad for all the training, extra training that we need to do, WHO fellowships, Commonwealth fellowships. Watched our juniors to also train themselves. Dr. Vatsala, Nutan, they went abroad, learned fetoscopy because I needed assistants to do the fetoscopy, fetal endoscopies. So many factors came into play. But I think passion, hard work, these things are important. I think you remember, everybody in Delhi tells me about the time when Dr. Bakshi, she had to go abroad, but there was an intrauterine transfusion to be done. And whole day we were so busy, we couldn't do. And it was in the evening. Then she said, you all go home, have dinner, come back at 9 o'clock. My flight is at 2 o'clock. I'll go straight from here. So we all went home, came back at 9 o'clock and started the intrauterine transfusion. She came, she did it. Her husband was pacing the corridor. You're going to miss your international flight. But she did it. That is the culture of AIIMS. Once it also so happened that I was going to Pune, Sunita must be there, and I was doing some inspection, but my assistant, Dr. Vatsala, called me, and that time she was not very confident with IUTs, that there is a patient with hydrops referred. So, if you don't do the transfusion, next day the heartbeat will not be there. So I said, okay. get the case ready, I'm coming. So from Pune, I was doing some inspection. I don't know whether it was health or MCI inspection, and I paid my own fare. I came to Delhi straight from the airport. I came to the OT, fetal medicine OT. I did the transfusion, and then I went home. They were surprised. They said, "What are you doing here?" And then early morning, I took the flight back and continued with the inspection. So that
Yes,
sort of a passion, that sort of a dedication is something I really haven't spoken much about this type of things to you. I don't think you know about it, but this is how, you really have to work hard, sincerely.
Thank you so much, ma'am, because you've really given us how you live by examples. And I think truly you've brought mentors to be blessed by mentors as good parents, to be blessed by teachers who've literally handheld. And of course, I think it's a blessing, which I learned. But the mantra of success you truly told is passion, perseverance, and patience, which you really lived up. And you really taught us. But then, I think I would really want to share something to my viewers. She's been a role model, and truly, even she may say she was not the head of department, we always felt her to be a leader par excellence. I always remember they never needed to go to an MBA school, but to be trained under Dr. Decker. She's an institution in itself who's trained so many, and I think her followers are in voluminous numbers, and that's a testament of the way she gets a group on fetal medicine going, where people reach out to her despite her busy schedules and a busy practice. But I would just want to take, a little bit of your advice to give to the people who are watching and to a lot of the youngsters, or what you think of being a good leader. Who should be a good leader? We know you've been one of the best leaders that we've had. So how do you see you could rise to be a good leader in any organization? It's not just obstetrics and even any walk of life. And I think this message would go a long way to sort of influence the youngsters.
See, the leader should have the leadership qualities. These leadership qualities are number one, passion for work, and passion to mentor the people under them. And first of all, you need knowledge, you need confidence, you should be able to communicate very well, you should have love for your people whom you want to train, you should be able to see what goodness, what qualities are in them. So, if you pick up the qualities, and then not everybody is going to be good at everything. So if you know what qualities to hone them in, then you bring that person's confidence up, you bring that person's vibrations higher up, you are able to make that person perfect in what that person does best. So I have, all over these years, I know who is very good at writing. I know who is very good at operating which type of surgery. And then I know who is good at teaching or making slides. I'm just talking about simple things like that. And that is how you can train that person to do better in what he has the knack. So that is one thing. Next thing is, of course, the person whom you're training to become a leader. That person you have to inspire. You have to inspire, you have to give the pep talks. Some people, they think they will not be able to do it, but you should be able to make them confident that why not? You can always do it. Everybody can do what they're good at if trained properly, if given the hope that they can do well. I think that's very important. Persistence, patience, perseverance. These are some qualities, and nothing like hard work. The other thing is, you should not boss over people. A lot of people have told me you don't, behave like an AIMS professor. A lot of people have told me that you don't. I said, what is the meaning of it? Unfortunately, some people have this idea that professors should be very snooty, walk around with their nose in the air. But then you're nothing actually. It's just that your luck that you are where you are. You could have been born somewhere else. You could have not been able to do it. So do what you have been given by God. Don't think that you are better than anybody else. Try to bring the other people up to your standards. Don't boss over or bully other people. That is what I think makes you someone to others will admire.
So beautifully and aptly said. I think you put everything in such simple words. I would simply say a leader who looks backwards, a person who's simple enough to recognize a person. I said, as human beings, we want to be loved, appreciated, and that's what we've learned from you. I think we've had a real great time, ma'am, with you. With moving from healthy beginnings for hopeful future. If that's the slogan, I think you really turned around the whole, topic and given us so much of hopeful future for youngsters who will really, really watch this podcast, and I think they will read and would like to hear this back and forth again, because of the kind of tips that you've given to all of us to appreciate others. I think that's the most important thing.
Yeah. One thing I forgot to tell is that, when you're talking about being a leader, a role model, you have to be mentally healthy. You have to make your colleagues very comfortable. You have to make them at ease so that they can work in an atmosphere which is most conducive to mental health, which will reflect on the work.
Certainly, I think it's looking at and appreciating the goodness in each one of us. I think that's where I would say a good leader would like to. So thank you so much, Dr. Decker. We've had a very nice time with you. I wish we could go on, but I think with paucity of time, as we are supposed to wind up, I again thank you so very much for coming on this podcast and again being a leader and a mentor to so many of your followers, including me. Thank you very much. Thank you.
Thank you very much for giving me this opportunity. Dr. Neena and Dr. Sunita Tandulwadkar, thanks a lot.